All right, well, welcome back for the thrilling conclusion of Chapter 4, Tissue. So last time we left off talking about connective tissue proper. So we talked about loose and dense connective tissues, and then we talked about cartilage. So most of the rest of these I'm just going to kind of touch on because many of them we either get to in much greater detail in the other course in PEPROF 201, or we get into in greater detail in later in this class. So bone is one of those that we get into in much greater detail in 201, but just as either a primer or a refresher, either way. So bone is osseous tissue, and so anything osseous or osteo deals with bone. So there's a couple terms on there. There's osteocytes and osteoblasts. So to tie that into what we talked about last time, remember that the first part of the word tells you the tissue type, so osteo is bone, and then the second part of the word kind of tells you what stage that cell is in, how mature it is, if you will. So osteocytes then are fully mature bone cells. Osteoblasts are immature bone cells. In the case of bone, the osteoblasts are going to be the ones that are going to lay down the extracellular matrix. They produce lots and lots of collagen. And then that collagen, it sort of acts as a scaffolding. And so we add to it some bone salts. And whenever we add in those additional bone salts, that's what gives the matrix its characteristic hardness of bone tissue or osseous tissue. Like in the other class, I'll refer to them as calcium crystals sometimes as well. And so what ends up happening then is those osteoblasts kind of paint themselves into a corner. So they secrete all this extracellular matrix, and then we calcify or ossify that extracellular matrix. And so then they're just kind of stuck in this little hole in the bone that's called a lacuna. And then they do have connections to the surrounding osteoblasts that become osteocytes that helps them communicate with each other, but that's also in part how they get their nourishment. So there's two types of bone tissue. So there is cortical bone, which is dense, it's really dense, hard bone. That's what's pictured there. And then there's also trabecular or spongy bone. And so if you've seen the like inside of a bone where it's got sort of that spider web network inside of the bone, that's the trabecular or spongy bone. So what you see here is cortical or lamellar bone, and it has this repeating pattern where there's this central canal that has an artery, nerve, and a vein, and then you have these rings called lamella of calcified tissue, and they're concentric rings. They get progressively larger as you move farther and farther from the center of that cylinder. And these little dark spots here, those are the osteocytes. So those are the mature bone cells in their little lacuna. So the osteocytes are essentially responsible for a couple things, really. They maintain the matrix, so over the course of normal use, you're going to get some compression, some tension on the bone, and so that's going to cause some fraying and breaking of some of the collagen fibers in these rings. And so the osteocytes are in charge of repairing any of that damage, but in addition to that, they kind of direct remodeling that happens in the bone. So our bones are constantly changing; they're in a state of flux. So if you let's say take up an exercise program, you start loading bones more than you have previously, there are particular areas of the bone. So in the case of somebody who's takes up a running program, the neck of the femur bears a lot of that weight. It has a lot of compressive forces on the inferior surface and tensile forces on the superior surface. And so because of that, that bone's going to remodel. It's going to lay down additional lamella, these little circles of bone tissue, in both the superior and inferior aspects of the neck of the femur to try to reinforce that. So that's part of the remodeling process. Other things about bone, so the cavities in the middle of the bone serve as important sites for fat storage. So that's kind of between the little spicules of the spongy bone. And then bone tissue is also important for synthesizing blood cells. So particularly your flat bones, so like the bones of your pelvis, your sternum, your ribs, your skull, that's where we make a lot of our red blood cells that are going to carry the oxygen that we need to deliver to the tissue. And we also make some of our white blood cells there as well. Make sure I didn't miss anything. Nope. All right. There's one more thing. So bone and cartilage are pretty similar, but there's a couple major exceptions. One is, of course, that bone is calcified, so we have those bone salts that are placed between the collagen fibers to make bone hard, and your cartilage is not that way, so the cartilage doesn't have those bone salts in it, obviously, because they're called bone salts, so they're in bone. But then the other part about that is that bone is really vascular, so it has lots and lots of blood vessels, which you might have guessed, since I mentioned earlier, these central canals have an artery, nerve, and vein in them. So there's a good blood supply, there's another one, there's another one. And so then you have these other canals that are harder to see here, and actually don't see any really obvious ones, but you have other canals that basically run perpendicular to this to help with the blood supply. So blood then is very vascular, and why that matters is that in general, vascular tissues with a good blood supply, repair themselves really well. So fractured bones, typical healing time, somewhere in the neighborhood of 4 to 6 weeks. And then essentially that bone's going to be as good as it was before. So their bones are really good at repairing themselves. And then the next one, oops, went too far. Next one is blood, and so blood is one that we're going to talk about in a couple modules. We're going to get to, there's a whole module on blood. For now, the two primary components of blood are red blood cells, and the technical term for that are erythrocytes. So two primary components of blood, you got your erythrocytes, and then you have your plasma. And the plasma is the fluid that the red blood cells float around in. Of course, there are other things in blood as well. So WBC stands for white blood cells. So you can see a couple of them on here. So there's a lymphocyte over here, and then a neutrophil over here. So those are going to play an important role in our immune response. And then we've also got platelets. And so the platelets are going to play a role in clotting, is kind of their job. The overall job of blood is to, of course, transport things. And the primary thing or things that blood transports are oxygen and carbon dioxide. But in addition to those, it also transports things like fats, amino acids, glucose, hormones, all kinds of stuff. So blood is kind of the body's superhighway where we get things where they need to go. But again, the primary two things that blood carries are oxygen and carbon dioxide. Then we got muscle tissue. So we're going to obviously get into these more later in the class as well. We talked a lot about skeletal muscle in 201. So in case you didn't remember or haven't taken it yet, skeletal muscle is voluntary muscle. So it is, when we talk about your biceps brachii or your quadriceps muscle group or those kinds of things, those are muscles that you can intentionally cause to contract. You can think, okay, I want biceps to contract, boom, it does it. That's skeletal muscle. Cardiac muscle, on the other hand, we only find that in the heart. So this is skeletal muscle, it's pictured for you here, and so apparently it's supposed to be the triceps. But so this is skeletal muscle. The fibers run in parallel with each other. And one of the other names for skeletal muscle is striated or striped muscle, and you can see the striped appearance of the skeletal muscle here, where there's this repeating pattern of dark and light and dark and light, and that's from the overlap or not of the contractile proteins found in that skeletal muscle. As opposed to cardiac muscle, the shape is a little bit different. It's also striated. There's some overlap and not in the contractile proteins, but it's shaped different in that the fibers actually merge with each other and they split. So whereas on our skeletal muscle fibers, they're just tendon to tendon, straight down the line. When we get into the cardiac muscle fibers, here's one, and it's going to split. Here's one, and here's another one. So they actually directly adjoin neighboring muscle fibers, and then they have these things, these intercalated discs, which is the point at which they meet the neighboring fiber, and those have gap junctions in them, and so that allows the transfer of ions, electrically charged particles, from one cell to another. And the reason that matters is that allows for orderly contraction of the heart muscle, because we need the heart to basically contract from the bottom up to wring, at least in the case of the ventricles, to wring blood out of the heart and eject it either to the lungs or out to the body. And then our last type is smooth muscle. And so you can see here, so smooth muscle, you don't see that overlap of the contractile fibers, and so it doesn't have that striated appearance like the other two. Smooth muscle surrounds the organs of your gastrointestinal tract, so around your esophagus. So when you swallow something, you're going to get smooth muscle contraction that's going to start up in your throat and then go all the way down through your thorax and into your abdomen and carry that bolus of food down into your stomach. And so that's this orderly, smooth muscle contraction from top to bottom. And then we also have smooth muscle contraction around the stomach, around the intestines, etc., to propel things along the GI tract. You've got smooth muscle around the respiratory tract. So for example, when somebody has an asthma attack and they can't breathe, that's because of contraction of the smooth muscle around the bronchioles, around some of the airways in the lungs, and so then that makes it difficult to breathe. Got smooth muscles around your around some of your blood vessels called your arterioles, and that helps direct blood flow to where it's needed at any time. So one of the key differences there then is that smooth muscle is entirely involuntary. Cardiac muscle, also involuntary, but skeletal muscle is one that we can control. You can intentionally cause skeletal muscle to contract. Nervous tissue is another type that's covered extensively in 201. So for now, neurons are kind of the rock stars of nervous tissue. They're the ones that do most of the heavy lifting. So they are cells that are going to generate an electrical signal and then conduct that electrical signal down the length of that cell onto an adjoining cell. And so that's how we do things like think and maintain consciousness and activate skeletal muscle, all those kinds of things. So neurons are running that show. In addition to the neurons, though, we have these other cells called glial cells that are helper cells. And so, again, we'll talk about those in more detail in the other class, but they basically enable the neurons to do their job. So they maintain the electrochemical environment around the neurons so that they're able to conduct those electrical signals. Another important thing, because we'll talk about the endocrine system in this class, is that there are two important control systems for the body. The first is the nervous system. And so the nervous system is kind of this instantaneous control system of the body where we can send, one individual neuron can send more than 80 pulses per second. So it can send lots of messages per second as opposed to, and so again, it's that instantaneous response, as opposed to the endocrine system is hormones. So the endocrine glands then have to eject their hormones into the blood, and then the hormones have to circulate in the blood or the lymph to reach their target tissue and then initiate a chemical messenger system. So that takes a little bit longer, but the effects tend to last longer for the endocrine system. So the effects can last for days. Neurons are kind of on-off instantaneous response. All right, we're actually going to skip this part. Then let's talk about tissue repair. So if you damage tissue, you're going to start an inflammatory response. And so that is the repair response. So one of the things that we often do, especially in exercise, is we try to think about ways to sort of tamp down inflammation. So for example, if you go and exercise really intensely or you do something that you're not accustomed to and then 2 days later you're sore, that's delayed onset muscle soreness as we've talked about before. And so part of the reason that you're sore 2 days later deals with this inflammatory response because you have activated some of the immune cells to clean up some of the area if you've done really extensive tissue damage. And if nothing else, you've caused some swelling and sensitized some of the pain receptors around the muscle so that it's really tender if you palpate it or if you touch it. So again, we usually think about the inflammatory response as being negative because in a lot of ways it is. The inflammatory response, we associate with swelling, we associate with pain and redness and heat and all those kinds of things. And soreness in the case of muscles, and so obviously, nobody likes being sore. But that's an important part of the adaptation, and so there, a lot of the focus in exercise science, and strength training included, is related to sort of tamping down the inflammatory response. Because that's actually like one of the things that, if you get hurt and you put an ice pack on it, one of the goals may be to tamp down some parts of the inflammatory response. So in terms of tissue repair, depends on which tissue we're talking about as to how long each of these stages last. So I'm going to kind of lay out a general model for you. I'm going to use actually just a cut because I think that's the easiest way to conceptualize it, and conveniently, those are the graphics that came with the book, so that works out pretty well. But in general, tissues that have a good blood supply tend to regenerate pretty well. But some other tissues that don't have an especially great blood supply, so for example, your skin, is pretty good at regenerating as well, even though it doesn't have a direct blood supply. And epithelial tissues broadly are pretty good at regenerating, even though they don't have a direct blood supply. Well, how is that? Part of that deals with how often those cells are replicating anyway. So your skin cells are the deepest layer of skin cells, as we'll talk about next week, you've got some immature cells that are constantly dividing and making copies of themselves, so they're undergoing mitosis. And so skin is constantly turning over anyway, and so if you injure it, because it's already making tons of new skin cells all the time, it's able to repair itself pretty effectively. And we see the same kind of thing like in the intestines or in the respiratory tract. There's so much damage to those cells that they're constantly regenerating anyway, and so they're pretty good at repairing themselves. In addition to epithelial tissues being pretty good at regenerating themselves, bone, as mentioned a minute ago, because it has a good blood supply, is pretty good at repairing itself. Areolar connective tissue, dense irregular connective tissue, which we find underneath or in the deeper layer of the skin, as we'll talk about here in a second, but we also find that in joint capsules, as we talked about last time. Tissues that are not quite as good at repairing themselves include smooth muscle. So if you damage the muscle, around the gastrointestinal tract or something, not quite as good at repairing itself, but it's okay. It has a moderate regenerative capacity. And then dense regular connective tissue, which would include your ligaments and your tendons. Because their blood supply is not great, and in the case of tendons, they don't have a lot of fibroblasts, which are the immature cells that can make a bunch more collagen. Because the tendons and ligaments don't have a ton of those, they have the capacity to repair themselves, but they're not as good as something like bone that has a really good blood supply. And then tissues that essentially can't regenerate at all, neurons. So particularly those in the central nervous system. Now, if you damage a part of a neuron, so like the electrical cord, if you will, that the neuron conducts its signal through is called the axon. So sometimes, depending on where the neuron is located, if the axon is damaged, then neurons can repair themselves. But if the whole neuron dies, it's gone. So nervous tissue has virtually no regenerative capacity, and then the same thing for cardiac tissue. So heart musculature also has basically no ability to repair itself. So in terms of stages of the inflammatory response, as you can see there's 3 stages. There's the acute, which is right when it happens. Subacute, so typically acute is kind of that first 0 to 72 hours. So the first few days. It depends upon the extent of the injury. So, a torn ACL versus a cut to your skin are very different in terms of the length of each of these phases. But in general, the acute phase is give or take 0 to 3 days. The subacute phase is typically in the phase from that 3rd day approximately to as many as 4 weeks, and then the chronic phase is kind of after 4 to 6 weeks until we're done healing. So again, in something like an ACL repair or like an Achilles tendon rupture, both of those tend to have some longer healing times, and so that you might be in the chronic phase for several months after those injuries. But let's talk about what happens in each of those phases. So in the acute phase, so again, the example I'm going to use is in terms of the initial tissue insult is going to be a scrape of the skin. And so we've got here, even though we've already got the scab, we've got a scrape in our skin. And so we got 2 layers, because this will kind of tie into what we talk about next week. So you got 2 layers of the skin. You've got the epidermis, the most superficial layer, and then you've got the dermis under here. And then this little purple layer is where we've got those cells that are constantly making copies of themselves. So they're making new skin cells, and the skin cells are called keratinocytes. So they're making new skin cells or new keratinocytes all the time. And so our cut has gone through the epidermis, so the most superficial layer of skin, and it's gone down into the dermis. Now in the dermis down here, you have dense irregular connective tissue. So you've got lots and lots of collagen, but there is some extracellular matrix. There's not really much extracellular matrix up here in the epidermis. The cells are just kind of stacked on each other, and they have, as we'll talk about next week, desmosomes and gap junctions that attach them to each other as well. So not a lot of stuff, if you will, outside of the cells, but there's quite a bit of fluid in the extracellular matrix down here in the dermis. And then again, lots and lots of collagen going every which direction, because you've got dense irregular connective tissue, which again refers to the direction of the collagen. Dense regular, collagen all goes the same direction. Dense irregular goes all kinds of directions. So what's going to happen is when we get this cut, the initial phase is going to be vasoconstriction. So vasoconstriction means that the blood vessel closes down. And so what we're going to get then is vasoconstriction here. And so the reason that we would do that, so again, that's what that deals with is smooth muscle. So you've got this involuntary smooth muscle around some of these larger vessels, and so that smooth muscle is going to close down because we're trying to limit blood losses, because that's our first concern, is not bleeding too much. So the initial response is to contract the smooth muscle around the blood vessels in the area to decrease blood flow. And then, because there will be some damage to some of these capillaries, in blood you've got platelets, and what platelets will do is when there's damage to the blood vessels, or when they receive some signals from the mast cells, and we'll talk about those more in a minute, when the platelets receive signals from the mast cells, or they see exposed collagen, which will be underneath the blood vessels or deep to the blood vessels, then the platelets will just start to stick to that. And so the platelets then stick to that, they stick to each other. They also have this signaling cascade where if one platelet sees some exposed collagen and then attaches to this wall of the blood vessel here, it'll then signal. That'll cause 2 more to come, they'll cause 4, etc. And so it's a positive feedback loop, and so water falls really quickly and attracts tons of platelets to the area to shut off bleeding or keep blood from leaving the blood vessels. And so that's when a clot is formed. So then this is all the kind of mesh work from all, and because some of those platelets are going to actually slip out of the blood vessels and again cling to this collagen out here, and so then that's what helps form the clot. So the vasoconstriction itself occurs for give or take 5 to 10 minutes. We're going to form the clot, we're going to stop the bleeding. So that's our primary concern. At the same time, you also have mast cells. So mast cells we talked about a little bit in the previous lecture. So mast cells are often referred to as a type of like sentinel cell. They're on guard, and they line up along blood vessels for the most part, but they are also kind of scattered throughout this dense, irregular dermis here. And so what mast cells do is they initiate that inflammatory response. So if they are themselves damaged, or if they sense chemical messengers coming from these damaged keratinocytes or from exposed proteins from these collagen fibers, they're going to start this inflammatory cascade. And so they've got these little vesicles that have a variety of variety of chemical messengers in them, not neurotransmitters, variety of chemical messengers in them. And so then they're going to release all of these little chemical messengers out here into the extracellular space, so into the extracellular matrix in that dermis. So, for example, histamine is one of the inflammatory chemicals, or one of the messengers released by mast cells. And so one of the things that histamine does is that it's a vasodilator. So it's going to do the opposite. So dilation is to open up. So it's going to do the opposite of vasoconstriction. So histamine is actually going to cause the smooth muscle around this blood vessel to relax. So it's going to cause it to open up. In addition to that, they also release a neutrophil chemotactic factor, or NCF for short, and so that attracts neutrophils, which are a type of white blood cell. So they'll come to the area and help clean up or attack any invading organisms, bacteria, those kind of things. And then serotonin is going to increase capillary permeability. So inside of your capillaries, you have, again, a special type of epithelial tissue called the endothelium. So you've got these simple squamous cells all attached to each other that sort of form the inner wall of the blood vessel. Well, when they're exposed to serotonin, it allows those epithelial cells, those endothelial cells more specifically, to pull apart from each other. So it opens up some gaps. And then by opening those gaps, we get white blood cells migrating out of the blood vessel. So normally, these white blood cells can't get out, but if we open up the gaps between the cells and the endothelium, that allows them to migrate outside of the blood vessel and out into this area where there might be invading microorganisms, or where at the very least there are damaged cells, fragments of cells, collagen fibers that have been torn, all those kinds of things that are going to need cleaning up. And so serotonin allows those immune cells to leave the blood and get into that underlying connective tissue. And then we also have heparin. And so heparin is an anticoagulant, so it'll allow, rather than starting to get some more clot down in here, it'll allow these blood cells, these white blood cells, to migrate more easily into that dermis. And so one of the things that's going to happen here is as all these big white blood cells migrate to this area, it creates this osmotic gradient. So you've got a bunch of big cells fairly concentrated in this extracellular fluid. And so by doing that, remember that water wants to balance out on either side of the membrane. So in this case, water wants to balance out in this dermis. The concentration of the solution of the extracellular fluid in this dermis wants to balance that concentration with what we find in the blood. And so because you've got a whole bunch of white blood cells in this small area here, that's going to create this pressure pulling water from the blood out into this area. So why does that matter? Because that's one of the things that's going to cause swelling. So the reason you get swelling after an injury is really kind of twofold. One is that osmotic gradient pulls water out of the blood vessel, so pulls plasma, the fluid portion of the blood, out of the blood vessel and into this tissue. So that's going to cause fluid accumulation. But we also combine that with these chemical messengers. So if histamine is a vasodilator, we have more blood in the area anyway because we already opened up this blood vessel, opened up its diameter, and remember that serotonin is going to increase capillary permeability, so we've made it easier for that fluid to leave the blood vessel. And so the combination of those two things leads to that very characteristic swelling that we associate with an initial injury. So whether it's a sprained ankle or an ACL tear or just a cut, you're going to get swelling pretty quickly after the event. And again, it's because of both of those two primary reasons. Basically, this combination of chemical messengers, especially these two, histamine and serotonin, plus the osmotic gradient created by all of the white blood cells in the area. So again, this initial phase, the acute phase, typically lasts 0 to 3 days. Now, with more traumatic of an injury or more severe of an injury, this can last a little bit longer. So if you have a grade 3 ankle sprain, then that can last for a few more days on top of that. All right, so then in the subacute phase, and so you can see what happens in the subacute phase, we get repair and then proliferation. So if something proliferates, we make more of it. And so we're going to get a proliferation of fibroblasts, the cells that make more collagen. They're in connective tissue. Or you get a proliferation of the keratinocytes, the skin cells as well. So what ends up happening there, so again, you've got this clot initially, and so the white blood cells go into the area, they attack any invading organisms, but then some of the big cells, like the macrophages, are going to go through and chew up any of those torn collagen fibers, right? So that if you may have like some little fragments of collagen kind of floating around in the extracellular fluid, and so the macrophages are going to go in and clean that up. So then the next thing that's going to happen is you're going to get the clot gets replaced by granulation tissue. And so granulation tissue, what is that? It's a combination of fibroblasts, so those immature connective tissue cells, as well as the collagen that they generate, and then capillaries. So you're going to get fibroblasts migrating to this area. Fibroblasts from nearby are going to undergo mitosis, going to make a bunch of copies of themselves, and then they're just going to start making lots and lots of collagen. So they're just laying down collagen everywhere. And so that is this granulation tissue here, primarily it's this collection of all this collagen that these fibroblasts are laying down. And so we're trying to get rid of the clot that was created by the platelets, break that down, and again, some of the white blood cells are going to play an important role in that, particularly the macrophages. We're going to break down the clot, replace it with this granulation tissue, which is largely collagen. But a couple things to know about that granulation tissue. One is that it is disorganized. So those fibroblasts are just making collagen as fast as they can. And so the collagen self-organizes or self-assembles, and it goes in all kinds of different directions. So it's this very disorganized mesh of collagen. And the type of collagen that they create is type 3 collagen. So it is fairly weak. So it is collagen, but it's really, really elastic, and it's easier to tear, relatively easier than type 1 collagen, which is what we'll replace it with later. So that's our granulation tissue. As mentioned, the fibroblasts are going to either migrate to the area from nearby, because you'll have fibroblasts out here. So they can either just move over, and other ones are going to make copies of themselves, undergo mitosis and make copies, and so then you've got more fibroblasts in the area. We've also got some fibroblasts that are going to be involved in wound contraction. And so those fibroblasts are called myofibroblasts, and basically they're going to align along the ends of some of those collagen fibers and kind of pull it together. And so they're going to play a really key role there in that wound contraction. And then eventually the wound is going to remodel, so we'll kind of get rid of some of those extraneous collagen fibers we don't need, and the wound will remodel along lines of tensile stress, which is where it's being pulled apart. So that's particularly important if you think about like a ligament. So let's say you sprained your ankle and you stretched out your ATFL. The initial response is going to be to just lay down collagen everywhere, but we want the ATFL to do what it does. And so eventually, with some movement, those fibers are going to realign lengthwise in parallel with the other fibers and in parallel to the line of tensile stress where that ligament gets pulled apart. Let's see, trying to make sure I hit on all the important things I want to talk about. Yep. Okay, good. So that's the subacute phase. Again, depends on the extent of the injury, but typically lasts somewhere in the neighborhood of 4 to 6 weeks. Now, if we're talking about a cut like this, it may last a couple weeks, maybe less. As you can see from the label, you're also going to get some regeneration of the epithelium. So we're going to make a bunch of new skin cells, starting down here. These deepest layer cells, or deepest layer in the epithelium, or epidermis, sorry, are going to make lots and lots of copies of themselves, and so then that'll, as we break down that clot, they'll start replacing it from the bottom up. All right, and then we move into the maturation phase. And so what ends up happening in the maturation phase is kind of a continuation of that scar remodeling. But in addition to that, we're going to lay down or replace some of those weaker type 3 or reticular collagen fibers with type 1. So we're going to make the scar stronger. So you see that that's actually kind of what we're going for in terms of rehab. So again, sticking with the ankle sprain model, what we'll do, obviously, so I mentioned that the subacute phase lasts 4 to 6 weeks. So you're obviously going to start doing some range of motion stuff and moving the joint around much earlier than that. And so then you'll move from just moving the joint around to putting weight on it to doing some resisted stuff. And so what you're trying to do with all of those things, obviously you're trying to strengthen the muscles around the joint to help stabilize it. But in addition to that, one of the other goals is that you're trying to get some of this tissue remodeling to go on. And so if you're, stretching the ligament a little bit and then contracting the ligament a little, well, it's not going to contract, but if the muscles around the ligament are contracting, causing it to shorten, then that's going to help with the remodeling of the scar tissue and the ligament. And then again, during that whole process, we're going to replace the weaker collagen with the stronger collagen. And by doing that range of motion stuff, by doing those strengthening exercises, you get where the fiber alignment improves, again, along the lines of stress. But one of the things to know about tissue repair is, in most cases, that repair, that scar, is not as good as the original tissue. So it's, in the case of skin, it's maybe not as extensible as the original tissue. It's probably got a lot more collagen fibers in it, and so it's a little more rigid, and so you may have like a raised scar after having this cut. That's those collagen fibers there. So they're a little bit different than that initial epithelium, or in that case, epidermis that was there, because there's a lot more collagen in there and fewer keratinocytes in that case. So scarred down tissue in general, not quite the same. And where that matters is in places like heart attacks. So one of the most common places, or more common places to get a heart attack, essentially what happens, so with a heart attack, usually there is some narrowing of an artery. So you're familiar with the idea that if you eat foods like high in saturated fat, for example, that can cause plaque to build up along the artery walls. And so if we have an accumulation of plaque building up here along the left coronary artery, then as that plaque accumulates, it narrows down the blood vessel. So it sort of collects inside the blood vessel and narrows down the space. So if you've had a relative that, they said they went to the doctor and their blood vessel was 95% occluded or something to that effect. So the blood vessel was 95% blocked by plaques. There's not a whole lot of space left in that blood vessel for blood to continue to flow through to deliver oxygen to that myocardium. So what can happen then is a couple things, really. One of the common things that can cause a heart attack and is depicted here. So you get an artery obstruction. So maybe they have a clot that then gets stuck in that mostly occluded blood vessel, and when that clot gets stuck there, it cuts off blood flow to all of this part of the myocardium. And so when tissues lose blood flow that should be getting it, those tissues die. And so as a result of this heart attack, let's say we're able to, get this person to the hospital, they revive them, we restore normal heart rhythm, and they've recovered. But even though they've recovered, some of that heart tissue was cut off from its blood flow, and so it's going to die. And so then that myocardium gets replaced by scar tissue. So it's not contractile tissue anymore. This is basically just all collagen. And collagen doesn't contract. And so what ends up happening then is the heart is now weaker after that heart attack because of the infiltration of some of the myocardium with scar tissue. And so this is one of the things that kind of leads people downhill, where even if they've survived a heart attack, now the heart isn't as strong, so it doesn't eject as much blood with each beat, slows down blood flow, and so then that can also cause problems in the lungs, where that slowing down of blood flow can cause some fluid accumulation in the lungs, which can then predispose them to things like pneumonia, so bacterial infections inside of the lungs. And so it's kind of this, can be kind of this downward spiral where they have one heart attack, maybe a second heart attack, and then that leads to progressive loss of myocardium. Heart doesn't function as well, doesn't pump blood as well, and so because of that, you get a slowing down of blood flow, fluid accumulation in the lungs, etc. And so what I'm describing there is something called congestive heart failure, which is a fairly common condition, because as our acute care has improved for heart attacks, more and more people are recovering from the initial one, more and more people are surviving, but then again, that's going to kind of lead them down the road toward heart failure. So yeah, common condition. And then the other thing, and we'll get into this more when we talk about the heart later in the class, but the other thing that can cause a heart attack other than this blood vessel getting fully occluded from a clot or something, is basically they're doing work that they're unaccustomed to, and because of the narrowing of that blood vessel, you just can't supply enough oxygen or enough blood initially, which thereby you can't supply enough oxygen to that working tissue, and so then that ischemic tissue, it throws off the rhythm. Ischemia means lack of blood flow. That ischemic tissue then, it throws off the rhythm, and so that then can trigger the arrhythmia of the heart attack. But like I said, we'll talk about that in more detail later. So how that relates to what we're talking about now, after you survive a heart attack, that part of the heart gets replaced by scar tissue. The heart's just less efficient, and so then that leads to heart failure. All right, but for tissues that do heal, because again the myocardium doesn't, for tissues that do heal, how well they heal depends upon what it is, which tissue that we're talking about. So as mentioned, cartilage has a relatively limited capacity to heal itself, in part because it doesn't have a direct blood flow. Remember that it gets most of the nutrients that it needs either from the synovial fluid, so the fluid inside of the joint, or from the layer of connective tissue on its superficial faces, which is called the perichondrium, that does get direct blood flow. So cartilage doesn't have good access to blood flow, so it's not very good at repairing itself. When cartilage does repair itself, so what you got pictured here is a medial meniscus tear, and so that's one that's not going to fix itself. Other things, so like osteoarthritis is wearing down of the articular cartilage inside of a joint, and so to get cartilage to repair itself, one of the more common ways to do that is to basically do, it's called microfracturing, and so basically they'll drill a bunch of little holes inside of the joint, and so by doing that you expose that underlying cavity inside of the bone, and you allow some stem cells, some immature cells that can differentiate into multiple different types of cells. You allow them to migrate from inside of the bone into the joint space, and so then hopefully the goal behind that is that they're then going to attach around that wound and to nearby collagen fibers and start to generate a tissue that is not cartilage, but it's similar, it functions similarly, it still can cushion the impact, and allow the bones to slide relatively smoothly on each other. As far as ligament healing goes, it depends upon what type of ligament that we're talking about. So if we're talking about a ligament that is inside of the joint, so we've also got a torn ACL here. So if we're talking about a ligament that's inside of the joint, actually it's just a cut ACL because the PCL is cut here too. Sorry, I keep getting sidetracked. Ligaments inside the joint don't heal very well, like the ACL, like the PCL. And the reason for that is when there's bleeding from the ACL and you start to regenerate some fibroblasts here, every time you move the knee, you're going to squish around some of the synovial fluid inside of the knee. It's going to push it forwards and backwards. And so by doing that, you tend to knock the clots off and you knock that immature repair tissue off as well. So ligaments that are inside of a capsule don't heal very well. Ligaments that are outside of the capsule do tend to heal fairly well, provided you don't continue to stretch them for a little while. So you give them a little bit of time of immobilization or semi-immobilization so that they can repair themselves. But when even extracapsular, or so outside of the capsule ligaments heal, they do so by laying down additional collagen, and so the result is that those ligaments are functionally and structurally longer. And so then that's what, like one of the examples I use in the other class all the time was, once you stretched out a ligament, it stays stretched out, and so if you sprained your ankle once, you've probably done it more than once because of that laxity or looseness in the ligaments, because of the way they repair themselves by laying down additional collagen and becoming longer. Muscles are good at healing themselves within limits. So, if you lift weights or something and get sore, that's damage to the muscle. The muscle is going to repair itself and it'll get stronger. So they're pretty good at repairing themselves. If you get really big tears of a muscle, so if you get a grade 3 rupture of your hamstrings or something like that, muscles are less good at repairing themselves. They do have satellite cells in them, which are, we talked about this in a lot of detail in 201, but satellite cells are these immature cells that play a key role in repairing skeletal muscle. So the satellite cells are going to kind of migrate and try to lay down new contractile tissue. You're going to have fibroblasts, they're going to lay down new connective tissue, but muscle healing can be a pretty protracted process, so especially if you've got something like I said, with the full hamstring rupture, that may take longer than ligament healing. So that may be, several months in order for a muscle to fully heal itself. As far as tendon healing, it takes a really long time because, again, tendons don't have a very good blood supply. They don't have very many fibroblasts. And so when you get damage to a tendon, healing time is often more than a month, depending upon the extent of the damage as always. But because we don't have a lot of fibroblasts, because we don't have a very good blood supply, it takes a long time to heal tendons. And again, across the lifespan as we age, you get less fibroblasts and even less blood supply. Some of the capillaries go away, and so our ability to heal our tendons when they're damaged goes down as we get older, particularly as you start to get into the 40s and 50s. And part of that, again, deals with lifestyle too. People move less, but some of it's just the natural aging process. So things that make healing take longer, obviously the extent of the injury or the severity of the injury. A full tear takes longer to heal than a partial tear. Edema and hemorrhage, so edema is swelling, hemorrhage is bleeding. So if there's a lot of bleeding in the area, you're going to get a much bigger clot, and then the cleanup time takes longer. The macrophages have to go in and get rid of the dead red blood cells, and just takes a lot longer in the process. Poor blood supply slows everything down. If the tissues are far from each other, so for example there, not going to be able to bridge this gap. This is going to require surgical repair. Muscle spasm, so like after a hamstring strain or something, the muscles are going to spasm. They're going to involuntarily contract. That kind of pulls the injured areas apart, and so that then kind of produces some separation of the tissue. Corticosteroids are anti-inflammatories, and so again, because inflammation is part of the process of repair, if we tamp down inflammation too much by administering a bunch of corticosteroids, it makes them feel better in the short term, like the inflammation goes away, and so with inflammation comes pain. And so if you can make the inflammation go away, the pain goes away. But on the downside, you're not repairing the tissue, and so it can kind of lengthen the recovery time. Health, age, and nutrition. If you are in poor health, sedentary, pretty bad diet, you eat a lot of fried food and that kind of stuff, that can have a slowing down effect on the repair process. Obviously, as we get older, we're less good at it. Infection, I'm just going to mention this is mostly an FYI. So SHARPS stands for swelling, heat, ache, redness, pus, and streaking. And I mention that because sometimes students will come in and be like, not anymore, but when I was working as an athletic trainer, students would come in, or athletes would come in and be like, hey, is this thing infected? And so those are the signs you're looking for if somebody has that question: swelling, heat, ache, redness, pus, and streaking. We had an athlete who had gotten a tattoo and not taken good care of it, and had some pus in the area, but also had some streaking. And so what that means is you've got some spreading of that infection, and so obviously that's bad. So then we referred them to urgent care for that one. So, and then the thing on there, humidity or lack thereof. So wounds that are kept wet, and I mean with like a Neosporin or something, the more humidity you can keep in there, the faster the healing time. You don't want to just like have a wet Band-Aid on. That would be bad. But if you had, something like a Neosporin or petroleum jelly, those kinds of things help improve healing time on skin wounds. All right, so what? In sports medicine classes, a lot of times they'll talk about this concept of this pain, swelling, spasm cycle. And so the idea is that when you get that initial injury, so if you sprain your ankle, you've got the initial tissue damage that causes the inflammatory cascade, or a part of which is swelling, right? And so you get this accumulation of swelling, let's say around your sprained ankle. And so because of that, your ankle is going to really hurt. And so with that, it's going, you're not going to want to move it. You're not going to want to put weight on it. And so you then get muscle spasm, involuntary contraction of the muscles around the joint. And so what ends up happening then is if you don't move that joint, then that swelling just stays there. And so, and part of it's driven by gravity. So if we're talking about a sprained ankle, your leg hangs down all day. And so just that gravity starts to assist that inflammatory process and exaggerates that swelling. And so one of the things that we're going to do early on, and that you may have seen, RICE stands for rest, ice, compression, elevation. And so one of the rationales for, after you've injured yourself, after you've sprained your ankle, why somebody would stick an ice bag on there is that the ice bag is going to cause vasoconstriction, cause constriction of the blood vessels in the area, which will hopefully limit the swelling. And the more we can keep the swelling down, the more we can keep the pain down, which will hopefully make them more likely to move and reduce the muscle spasm that then also tends to cause pain as well. So the idea behind icing an injury right after it happens is to kind of arrest this pain, swelling, spasm cycle, because ice addresses both the pain and the swelling aspects of it. That said, ice is really falling out of favor with a lot of athletic trainers. I know several of them who act like if you still used ice for anything, that it's just, you're a dinosaur. But it is genuinely effective at reducing pain. And if people don't hurt, then they'll start moving. And when they start moving, you'll push some fluid back into the lymphatic system, and that'll drive swelling down. So I'm not sure I'm fully on board with the whole like ice is ridiculous, and if you use it, you're a dinosaur school of thought. Because of the way that it can kind of affect this cycle, and because, again, the way that it can cause or allow for a reduction in pain. And it's always nice if we can reduce somebody's pain for a little while. So that's the idea behind icing after an injury. The other parts of that, I guess I might as well explain. So if you don't keep causing insult to the initial injury, then hopefully that'll limit some of the swelling. Talked about ice. Compression and then elevation, those two. So if you just use like an ACE bandage, a stretchy wrap, put it on their ankle and then have them hold their leg up, that's going to do the same thing. So through that mechanical compression of the stretchy bandage and the effect of gravity, that's going to help minimize the swelling, and again, does the same concept. So if we can keep their ankle from swelling as much, then that'll limit the pain, etc. It's a similar concept like if somebody tears their ACL on the knee, those things just don't blow up quite as much. Well, obviously ACLs do, but as I was saying that, I was kind of mentally transitioning to an MCL injury. MCL injuries don't blow up as much as ankle sprains do, for example. But the swelling and the pain parts of that are still relevant, even though it's not as visibly obviously swelling. All right, so that's the end of tissue. So next week, as I promised, it's going to be shorter. We're going to talk about the integumentary system, which is the skin. And so it's definitely going to be one lecture, and I'm hoping to knock it out in like 30 minutes. So thanks for sticking with me through 3 fairly lengthy lectures on tissue and then some fairly lengthy ones on cells as well. So we'll see you next week for the integumentary system.